Hello. Yeah. So we will be starting with the live case demonstration. Yeah. Pointer. Yeah. Okay, fine, fine.
Check. Check, check, check. Check one, check. అది నాకు తొందరగా
హలో.
వాడు ఏజీలో ఉండి ఇమ్మీడియట్గా జాయిన్ అవ్వాలని వచ్చాడు. నాకు ఎక్కడ పోతుంది వచ్చి అంత गौन्स है.
హలో చెక్. హలో చెక్. హలో చెక్. హలో మైక్ చెక్. హలో. హలో మైక్ చెక్.
రెగ్యులర్గా ఎలా చేస్తామో అలానే వీ డూ ఎవ్రీ టైమ్ డూ ఇట్ స్టెరైల్లీ ఓన్లీ కదా. సో లెట్ us ఫాలో అవర్ ప్రోటోకాల్. స్టార్ట్
अरे वो ड्रग्स वो जो मैं बोला ना सोप दे दो ना లవ అక్కడ అన్నీ తీసి పెట్టా చూడివా డ్రగ్స్ అన్నీ అన్నీ రెడీ పెట్టా మేడం వాళ్ళు ఇవ్వాలంతే
गॉस बंडल दे दो ना अली में
10 degrees తీసుకో. లేదు నేను S1 రూట్కి చెప్తున్నాను. ఇంకో 5
Hello.
degrees ఇటు సైడ్.
Yeah.
Sir, Adductor canal.
Yeah. Good afternoon, everybody, for the
Ah, you
post-lunch
corrected it.
session
It is
of
itla.
live cases.
Right.
We are first demonstrating a regional anesthesia block, adductor canal block.
చాలే.
This is 71 years female, hypertensive, underwent right knee replacement now. So we are giving adductor canal block post-op analgesia. Dr. Bharti madam is demonstrating with Dr. Sai Tejas.
ఇది
So adductor canal block, as we discussed yesterday, it's a group of blocks which we call it motor sparing blocks. The femoral nerve block so far been this gold standard for the analgesia in the knee, but it was causing motor weakness and the patients, we were unable to mobilize the patient. But nowadays concept of the fast track and the daycare surgery also in the knee, it was not possible with the femoral nerve block. So these blocks, particularly the adductor canal block and the, yesterday we also discussed IPEC, both are alternative to the femoral nerve block. Here what we can see, this boat-shaped muscle.
Hello.
Dr. Lakshmi.
Yeah. Actually, this is a 77-year-old patient, as Dr. Nagalaxmi told. Today only she got operated, and we are doing adductor canal only. IPAC is not getting demonstrated because it's already there is a bandage and all. So, and now the position of the patient is supine and slightly laterally externally rotated. The limb is externally rotated, and I'm putting. We are using only the the linear probe only, and I'm putting on the middle of the thigh, and we can see the femur shining, that semicircular part, which is shining. And as I'm going, and we are going medially. Usually it starts with usually we adductor canal to be given in the mid thigh, but here the patient is very short and there is a bandage, and I'm going just above the bandage, so I'm going medially. As I'm going, you can see the vastus medialis, which is laterally seen just above the femur, and as I am going more medially, we can see the sartorius muscle, which is a boat-shaped or oval-shaped, and above that there is a subcutaneous tissue. So, and we can see the vessels, which is the femoral artery, and also there are two veins. We can see when I compress, they are compressed. Like when there is a pressure on the probe, you can see two vessels which are getting compressed. So there are two veins, actually, if you see. And above that is artery, and we can see the femoral artery, which is pulsating, and it is uncompressible. And there is an oval-shaped hyperintense area, which could be the nerve, that is saphenous nerve, femoral branches. So if that, it's a continuation of the femoral nerve. So sometimes the nerve may not be so better visible, but still the main target is the femoral artery. And at 11 o'clock position, we usually give the injection. So I'm just passing inline. I am giving in plane approach. I am putting the needle inside. As my colleague is aspirating, I am going through the and the needle I'm going through, and you have to target the artery, and once you get the pop off of the membrane, and it's very close to, and not too much of pressure should be given, because the veins get compressed and we may miss the vein. As it, I got the pop off now. I'm just checking whether I'm there in place. Needle వస్తుందా? Needle? Needle. I'm moving. You can see the needle movement. Can you appreciate the movement of the needle? Can you appreciate? Yeah. I'm moving a little bit to know the needle position. I'm exactly in the position. Dr. Sai is given first normal saline to check the position. And once, so it is in position, and just to move a little up, because we want displacement of the vessels also. That is more approximate, very close to vessels actually. I am aspirate. And he is aspirating many times before giving the drug. I am giving 0.25% of sensoricaine. 1 minute. I'll just want to come out a little. Yeah. Yes, try. Where? Give again. I just went back again to redirect the needle. Yeah, I went. You can see. ఇప్పుడు పెట్టాను వెళ్ళాను లోపలికి చూడు. There, yeah. Yeah, may I give you? Yeah. Bit it in a little bit. Yeah, I'm there, no? Give. Put. I'm there, yeah. Yeah, give. Parle. Yeah, it's going. Going. Wait. Don't move. He's having needle pain. Ivu, itches. It's there. Kada? I'm there here. Aspirate, ma? Pierce avali. Yeah, I'm there. Now you can see the proper needle track and all. Give the drug. Drug ichese, I'm there. Yeah. Yeah. It's almost finished. You can see the spread of the drug surrounding the vessels, up and around the vessels also. And we are aspirating every few mLs after injecting. I can see the drug spread also. Yeah. You can see the needle track also, yeah. I'm moving a little bit, withdrawing so that it spreads better. Yeah. Yeah, you can see the nerve surrounding the drug. Now you can see the drug nerve surrounding the drug clearly, and this is the saphenous nerve which we blocked. It's done, yeah. Thank you.
So
Yeah.
you have seen the adductor canal block. It is, the canal is actually around, it's a perivascular canal, which contains your branches of saphenous nerve, nerve to vastus medialis, anterior branches of the obturator nerve, and the other nerves, branches from the common peroneal and
నేను ఇంకా దాని మర్చిపోయాను.
the concern is here, we may hit the saphenous nerve. There are a lot of discussions whether the saphenous or the nerve to vastus medialis are within the canal or outside the canal. So it depends where you are locating. And they come out from the canal if we are giving the lower 1/3. That is why we are now trying to give in the junction of the lower 1/3 and the middle 1/3 to get the best of all. Because if you give 2 up, then the drug might ascend up to the femoral area, because below the femoral triangle, this adductor canal starts. So if you give in the upper pole of the adductor canal, the femoral nerve may be involved. But if you give it end of the adductor canal, by the time the nerve to vastus medialis and the saphenous both have come out. So effect is not much there. Now something about the volume. The ideal volume, if you are at the appropriate place, is 15 ml. But if you give 20 ml, is good enough. But people have given the high volume adductor canal thinking that the drug might seep through the adductor foramina and can go to the posterior side, where other plexus, the branches of common peroneal and this part of the plexus which is made by the sciatic nerve will also be blocked, and it will be more effective than the adductor canal alone. So this is all. This is my particular suggestion. Never use the sharp needles. If you are a beginner, always use the blood needle or the Tuhi needle to avoid the saphenous nerve injury and also the inadvertent entry into the femoral vessel, which can cause the hematoma later on. Any question? A new concept has been discussed, not much. We call it as a subsartorial plane block. So as you have seen, above the artery there are the 2 facial layers. One made by the sartorius muscle itself, and another facial layer was there, which was covering the artery. So if you are at the appropriate place and inject or hydrodissect, artery will fall down, will be going down. So you have to give about 2/3 of the injection there, and 1/4 injection you can spare for the subsartorial plexus, just below the sartorial line. And people have seen that it is more effective than the single place injection. This is all about the adductor canal. But remember, adductor canal only addresses the anterior and the medial part of the knee. The posterior part is not covered, which is covered by the IPAC. So it is always complementary to give, for the better analgesia, the IPAC has to be given with the adductor canal. Question of continuous infusion or intermittent remains, both choices are there. Few people put the catheter, but practically at every place it is not possible. So single injection mixed with the dexamethasone, or few people are mixing the dexmedetomidine, gives good 10 to 12 hours on the analgesia.
Started up. Yeah. Thank you, Dr. Bharti and Dr. Sai Teja. Am I audible? Madhugar? Audible. Okay. Yeah. Sir,
Yes, ma'am, you are audible, ma'am.
yeah. Our second case is a 21 years old male with history of sports injury. History of sports injury 4 years back. SI joint, clinically it is an SI joint pain. Provocative tests are positive. SLR and all are negative. Spine examination and the MRI of spine is normal. He was comfortable with conservative treatment for the last 3.5 years. Now from the past 6 months it is aggravating. So here we are giving a diagnostic SI joint injection right side.
Fine,
Dr.
ma'am.
Umameshwar
Hello.
sir and Dr. Madhukar, please take on. Sir.
Hello?
Yes, sir.
Yeah, good afternoon all. Am I audible?
Yes, sir, you are audible.
Yeah. So the patient is prone and 2 pillows are below the lumbar area and in the chest area so that the lumbar lordosis is reduced. As you can see in the fluoroscopy, the C-arm is positioned in the lower lumbar region. Should? Yeah. So we know that it's in the center AP view. Now the patient has symptoms on the right side. Should please. So we are identifying which side it has to be done. So we are identified with an instrument. And we ask the radio technician to give an oblique tilt of around 15 degrees to opposite side. That is, many of the procedures what we do with the fluoroscopy are ipsilateral. This is the one procedure where we do the contralateral movement of this fluoroscopy. Should. The SI joint is made up of a bony unification as well as a cartilaginous unification. As you can see, give a mic to him.
Hello. This upper one third is anterior SI joint. Upper 2/3 of the joint is anterior 2/3 joint. This posterior below is inferior one is posterior joint, posterior SI joint. We need to align this posterior SI joint and anterior SI joint. For that, we are making the C-arm at 10 to 15 degrees tilt to the opposite side.
Thank you, Lakumar. Another 5 degrees tilt towards me. Some more degrees. Yeah. So that I can show them. As Laukumar is showing, that is the lateral margin of the SI joint, and the medial margin is medial to that line, and the lower 1/3 is the opacity. That is where you can see the darkening of the joint. The upper 2/3 is majority of times is unified with the bony unification. So what we are trying to do is we have to enter into the SI joint from the lower 1/3. Should. 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 A small injection. So local infiltration is done before any procedure. This is 1% lignocaine plain giving in the direction of the C-arm. In the lower 1/3 of the SI joint. Should. Factors కొంచెం తగ్గించుకోవాలి డార్క్ అయింది. Should. Should. There are two ways of entering it. Either it can be an intra-articular entry into the intra-articular space, or it can be a peri-articular entry. Both are accepted way of performing the SI joint. Should. Should. Should.
get better fluoro images. Fluoro images was blurred last time.
Are blurred there?
Yes, sir. I think the focus, it went out of focus of the camera, the fluoro images, sir.
Fluoro, okay.
Yes, sir. Now they are better, sir.
Yeah.
Shoot. 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 Yeah, shoot. I felt as though I have, it's like as you give spinal, we feel a loss of resistance, similar sort of a loss of resistance I have felt. Another 5 degrees towards me. I'm just tilting the CM for another 5 degrees to see whether it's in the intra-articular space. Okay. Shoot. Okay. So now I'm trying to give some half cc of contrast. Sometimes when you're giving, patient might jump because it's so tight. It can be a pain generator, no? Because of that, there is high chance that the patient may get some pain. Shoot. See, this is, you can see that the contrast is aligning around the border of the SI joint, and some drug is around the periarticular injection. So this is a confirmatory for us. We confirm again this in the lateral view. Lateral view, please. Shoot. Try to reduce the fat. Shoot. Water chapis. Height down. Some more down. Okay. Okay, yeah. As you can see, the lateral view, it appears, the contrast takes the shape of an auricle of the ear. So as my friend Dr. Laukarmar is showing the auricle of the SI joint. So this whole thing is the sacrum as well as the coccyx.
This is the coccyx. So this is the coccyx. This is the sacrum. And see the ear pinna appearance. See the needle is here. And see the ear pinna appearance.
So now we are giving the drug. So this is typical of a periarticular injection because the joint is so stiff that the contrast couldn't negotiate complete into SI joint. So we used 0.125% of sensocaine and echinocard. Shoot. Okay, that's the end of the SI joint diagnostic injection. Thank you. Dhruv?
Yes, sir. Yeah, any questions? Yeah, or I would like to summarize. Any questions? Yes, sir.
Yes, sir. Yes. Die and needle position. Yes, sir.
Hello?
Needle is a spinal needle, sir. You are using a spinal needle, sir?
Yeah, we have used a 23 gauge Quincke needle.
20. Yes. Few things. How many of you are comfortable with fluoroscopy and fluoroscopy guided interventions?
Sterling.
Fine. Good. So, for rest of you, so the thing is, with fluoroscopy, things are slightly different from ultrasound. With fluoroscopy, bone is our friend. And the second thing is, with regards to the first point that the sir talked about was positioning. Before that, classically the patients of SI joint will have a pain which is more while sitting. So patient having low back pain which is more while sitting, one of the DD is SI joint. How do we diagnose? Obviously the SLRT, everything is negative. The other thing which is going to be positive is a Faber test, flexion, abduction, external rotation. Easier way, what sir is doing, the patient, the classical alti-palti position, the patient is not able to do. That is one. Regarding the intervention part and the positioning, I would just need a pair of hands. Ek baar aana. So the thing is, when we talk about, so when we talk about the SI, the facets are like this. Right? So we put, or like this. So we put the C-arm here and we do it. Right? Something like this. But when we talk about SI joint, so in SI joint, the positioning of the joint is like this. So if we place the C-arm on the same side, you will be able to see the joint but won't be able to enter it. So imagine this is the direction. So I will be putting it and won't be able to enter. That is what I do. We put the C-arm on the opposite side and align it, and then we are able to enter. So that is what he was trying to do. Second thing what he was trying to say is that when we talk about this joint, it is a fibrocartilaginous joint. It starts with fibrosing from the top and going down. So the easiest, so the last part to fibrose would be the lowermost part. Therefore, whenever you are trying to enter, you try to enter from the lower part, because anyway it is a diseased joint, so it will have some degeneration. So fibrosis starts from the top, so generally you need to go down. Right? As we always do in fluoroscopy, we are converting a 3-dimensional structure into 2-dimensional. Therefore, whatever intervention we do, we need to confirm the needle position in at least 2 directions or multiple directions, multiple positions. Third, one more principle that I personally follow is wherever there is dye, there is going to be drug. Right? So, jahan pe dye hai, udhar drug hoga. That is why always and always confirm it with a dye. Right? And regarding the thing that sir rightly said, so even if you, because it's a tough joint, so even in periarticular, there are studies which say even periarticular injection is equally effective. And trust me, it is difficult to do it, because it's like something like this. It's a 3-dimensional. Any other questions? One of the undiagnosed or not so common causes of back pain, so that makes it Yeah, volume should be around 5 to 6. See, diagnosis, if you are going for a diagnostic block, do not try to overload. 5 ml is more than enough. 3 to 5 ml is good. Sometimes even if you are a very purist kind of a person who would just like to go for only local, just give 2 to 3 ml also. That is pure. But yes, if you are trying to give some diagnostic relief also, combining it with steroids, so 5-7. Usse, beyond that you won't be able to give also, because it's a very tight diseased joint. So you will need, as sir also said, that once you try pushing it, it will be difficult. Any other questions? So if you are starting with, sir, use 23, even you can use 20 gauge spinal, 22. It becomes easy to manipulate. No, sir. Complications? No, if you are done correctly, there are no major complications. The only biggest challenge is sometimes you are not able to enter the joint, and it can be quite frustrating. Even for the senior, sorry, we were just discussing, sometimes it can take hours and you have to just do a sort of a compromise. So it is a tough joint, but no major complication as such. But yes, if you do it in blind and try to do, then this is quite a safe procedure. Yes, sir. Anji? It can be done under ultrasound. Only thing with problem with ultrasound is that you cannot have a dye spread. Okay, but you can do. Certain vessels can be there, so you can have a vascular take, but otherwise no major. Sir would like.
Very vascular joint. Mostly the drug will be going in the vessels. So always check it whether the drug is going in the vessels. And if you inject too much volume, then it might precipitate the pain itself, because you have stimulated the joint. So keep the volume on the lowest possible. And it is very common to give intravascular injection. That as you are asking, why not ultrasound? Because you cannot see that where the drug is going. But all the most region, it is very vascular joint.
Image will decide, sir. So there is no like centimeters which we can tell you. Yes, sir. You feel as if you have fallen in a ditch. The easiest way, if you are walking in top, you feel it. I mean, there is not, to be very honest, and this is something which I would like to tell everybody. Now is the time of image guidance. So no centimeters, no feelings, nothing like that. You have to have evidence. You have to have dye spread. You have to confirm the position in at least. If you are inside, so for example, which I tell everybody, simplest example, if I am touching my tip of my nose, you might feel, yes, I am touching it. But if I am touching it, whosoever sees it will be. If I am at the right spot, irrespective of the image, it will. So that is image, I will be at the right spot. Therefore, whenever you are doing it, confirm it multiple images. There are standards like AP, oblique, literal. But apart from that, even 2 degree here, 2 degree here, 4 degree there, 5 degree there will also give you that.
Just a request, if we can split the screen or make a picture in picture wherein one we can see the patient and the other the C-arm image. So,
sir, can we have a picture-in-picture configuration?
For the next patient or this patient?
The next, I think. This is done, I think. You are done now, sir?
This is done. This is done.
This is done, yeah. So next time we will make sure.
I'll give 2 more tips for the SI joint. You see, there were the 2 joints, one anterior, one posterior. So you have to align that. But sometimes, maybe rarely, it is not possible. Whatever way you do, you can put the whatever direction of C-arm, and both the lines are not coming together. So remember one rule. The medial part is the posterior part. The lateral part is the anterior part. So keep this in mind. Another thing, what just Dr. Vibras said, when you have put in the needle and you want to confirm it, the best way, you rotate the C-arm. Whatever position C-arm was, you rotate medially 10 degree, bring down to the natural place or the home page, and then go laterally 10 degree. If needle is in the joint, it will remain in the joint. But if it is not in the joint, definitely one way it is shown that it is in the joint, the another direction it is outside the joint. So before you inject the contrast, because once you have injected the contrast, you are gone. You can't see the tip of needle, and then the rest you have to abandon the procedure. So second, you give not more than 0.1 to 0.2 ml of the contrast at the first go. Until unless needle is confirmed, then you give a half cc and then followed by the drugs. So if you follow that, your procedure will be successful. If you omit one of these steps, you won't be able to do it properly.
Any other question? I think we can move on to the next case, sir.
Yeah, thank you, Dhruv.
Thank you, sir.
So probably you could tell them now about what is the next plan after the diagnostic injection, what are the different modalities of treatment once the diagnostic is confirmed. So there are different options whether to do a conventional radiofrequency or you can do a cold RF,
Yes.
or you can do a sacral lateral nerve ablation of the nerves. So there are, once this diagnostic injection is confirmed, then the next modalities we can treat. Thank you, Dhruv.
Thank you, sir. Thank you so much. So one more thing, again, which I see sometimes lacking is, though in literature we come across a lot about diagnostic, because see, in pain, majority of the time, history is the best indicator, and there is no evidence. Therefore, to be very sure about the diagnosis, please do not hesitate to give a diagnostic block. Right? Because even in SI joint, you might have a patient which is suggestive of SI joint. MRI scans are more or less normal or inconclusive, or the radiologist is not ready to comment or commit. In that, do not, please go ahead and do a diagnostic block. There is no harm. Be honest to the patient. And trust me, I think, sir, everybody will, if you are honest to the patient will understand and give you a chance. So tell the patient that I feel, based on your history, the pain is coming from the SI joint. I would like to go for a diagnostic block. If it works, then probably we'll move ahead. And most importantly, this is just to get the diagnosis correct. Right? And please, one more thing. As I think I was discussing it with few of the people during the workshop, pain is a very humbling branch. I was not what I am, I think 5 years or 7 years back. Initial 5 years, I was a different person. Why I say so? When you give a diagnostic block, be ready to fail also. Don't make yourself believe that I cannot go wrong, or you try to convince the patient, nahi, yahi hai, you have relief, you tell me because I have read it. No. Be humble to say, okay, I don't think it is, we will find another cause. So that is, diagnostic is for diagnosis. So there is a 50-50% chance that it will be there or it will not be there. So don't try to convince yourself or don't go on an ego trip. I have gone there. It is not healthy for yourself and for the patient. You have to be honest to the patient. And trust me, the patient are, specifically chronic pain patients, are very forgiving. The maximum that I have learned is from my patients. So just be honest that I feel it is coming from the SI joint. I will give a block, come back if it is there, and then we will take it forward. If it is not, then we will probably find a better reason or which could explain your pain. Fine. Any questions? Block last depends on the local anesthetic, sir, you are giving. So, very good. So diagnostic, what I would suggest is that, again, very good question, because generally people tend to use lignocaine. I personally use bupivacaine because the patient should have at least 2 to 4 hours of relief, so that the patient is in a better position to say whether it worked or it didn't work. That is one. Second thing is, avoid giving too much of sedation. That is again important thing. Specifically, if you are giving a diagnostic block, do not over-sedate the patient. Because you give sedation, you have given some fentanyl also and everything. Patient is ko kisse relief aaya, we never know. Right? Counsel the patient that I need to limit things and then inject. Right, sir? And one general tip is, when you are doing these interventions, do not over-sedate the patient, ever. I understand it is a tense OT. Because you are doing it for the first time, you are tense. The captain of the ship is tense, so your staff is tense. Patient has all the right in the world to be tense. So it's a tense OT. So people, when you start off, ouch karta hai, sedate kar do. So the beauty of this intervention is that patient will never let you harm them. This is the beauty of all pain interventions. Even if there is an aberration with the nerve or anything, they will make sure that you will not harm them. The best control is the patient. So do not over-sedate. Thoda bahut anxiolytics theek hai. The thing becomes more profound if you are doing a diagnostic block. So just give local bupivacaine and see how the patient is responding, and then we can take. In fact, I think if we get a time and the patient commits, we can even ask in the post-op how is the patient feeling after the injection.
Diagnostic blocks work like in your experience.
So again, my experience. So if I am if I am giving a diagnostic block, so what I will be doing is I will be mixing bupivacaine with a little bit of steroid. So the bupivacaine effect will last for say around 4 hours. So I get the point. Second, the steroid effect generally in my experience starts working in 7 to 10 days. So what I generally counsel the patient is that I have given bupivacaine. Hopefully pain should settle down. Uske saath I have also mixed something which is an anti-inflammatory which will start kicking in. So once I have given a diagnostic block where I feel there is an SI joint, so I generally avoid giving a pure diagnostic block. So it will be bupivacaine mixed with steroids. Bupivacaine 2 to 4 hours, steroids that starts kicking in 7 to 10 days. Complete effect will be around month or so. So I ask the patient that we will see how long does it work and then we will take it forward. Any other question? If it is positive, so anti-inflammatories we have given, so steroid is good enough. Denervating SI joint is, there are very few patients where I have actually gone ahead and done something like this. So denervation and cool if there are multiple poking points, so generally I have not done. Anybody would like to that denervation part? Have you done?
So SI joint is supplied with L4, S1, 2, 3 and L5 median branch. We call it a ramus, dorsal rami of the L5. So for the denervation, we have to block those nerves. And it is practically difficult. That is why we give intra-articular injection to get the confirmation whether the SI is involved or not. Once diagnosis is confirmed, we can do the conventional radio ablation of these nerves. There are many methods. We can place multiple needles, or there are devices where they have cuts on it, and we place one needle, it has different cuts, and just we keep pulling that particular device and it ablates all the nerves supplying the SI joint. There are other conservative measures also that there are different methods like where to ablate those nerves. So they are not fixed that the nerve is coming out on this particular point. So different points. So for one nerve, at least 3 lesions we have to make. And there is another small device, epsilon, which showed E. We keep that E on the foramen, and all the branches of E actually depicting the possible site of emerging nerves. So all 3 places you have to ablate. And then what we do to reduce the number of punctures, we also do the bipolar ablation. So area is ablated instead of one place to get a better effect. But now the cool RF has come, which gives a larger lesion. So that is a preferred choice over the conventional RF. These are the choices we can do.
But the approach is more like carpet bombing. It's like a lot of lesions are there. Any other questions? I think we are moving on to the next case.
Left. No, side. కొంచెం పైకి
Hello.
Yes, ma'am.
This is our next case. It's a 33 years female with history of low backache and left radiculopathy from the past 3 years.
ఇక్కడ ఇద్దామా బాగా కనిపిస్తుంది.
Push it. Straight button. Push it. Push it. Push it. Push it.
They are trying to position the Siam.
Yes, sir.
Now the point with Siam, which I always tell everybody is that imagine the Siam as your eye. Right? So for anything that you want to see, you have to see it like an eye. So for example, you have the S1, the sacral are like one. SI joint was like this. What I was doing, we're trying to peep it. Whatever you do, imagine the Siam as your eye. You have to align the Siam in the direction, but in the anatomy. So like this, or when it is like SI, you go like this. When you go for transparapital, this is the transparapital, right? Lumbar region. What you do?
Chakra. Amisha, listen.
Open garden. Look at this. కొంచెం అడ్డుతాం.
In the meantime, anybody has any question, please.
Just a couple of minutes, Dr. Dhruv. We are just positioning.
No problem, ma'am. So with regards to positioning and the setup in which we do, see, the quickest source of knowledge for us is the YouTube.
The mic off, sir.
In YouTube,
The mic off, no?
we as doctors,
Mic off, no?
we from India have not put up so beautiful videos, though there are doctors. So we tend to go to Western population. They do things which are not so strictly septic, I would say, because for whatever challenges that they have. But what I will request everybody is that do these procedures in proper operation theatre with basic monitoring, with resuscitative equipment kept ready. Always secure an IV line. Okay? So these are the basic things. Do not compromise on that.
Yeah, the monitoring is connected. The patient has been secured an IV line and in prone position.
Yes.
This patient is an alpha S1 radiculopathy. She underwent an epidural steroid almost 1 year back with transient relief. So we are giving specific left S1 diagnosed S1 nerve root block. She underwent an interlaminar epidural 1 year back, which had relief for hardly 2 to 3 months. So this time we are being site specific, giving a left-sided S1 nerve root block.
Any chance have an orthopedician or a radiologist in the house?
Sir?
No, in the house, no, na?
Pardon, sir?
There is no radiologist or no...
Nobody, sir. All of us are anesthetists and pain physicians.
That is why I always feel very strongly from the bottom of my heart that the best people to do interventions are us.
Right, sir.
Not because we can do the procedure correctly, because we can manage the complications effectively.
True.
Right? And everybody will have a scary, the moment you put a needle, something happens. So you are trained, you will listen to the monitor fast, you will you will respond to them better. That is why do follow what you have been taught so far and do these interventions whenever it is needed. Yeah, I think now they are ready.
Yeah, we just want to combine it with both ultrasound and fluoro-guided.
Yes, sir.
So just connecting the ultrasound machine in a couple of minutes.
Yeah, so again, one thing in the last case they talked about putting in pillows. So pillows are put just to take care of the lumbar lordosis, so that the entry and everything becomes easy. Yeah, any questions with regards to so far? Anything? SI joint. Sir, SI joint again can be a part of a condition like Angst-Pond. In that case, it is bilateral. Otherwise, if it is trauma-related injury, I think last patient was a trauma-related, so that will be unilateral. So, for example, if a patient of SI joint, young male, comes to you, the first thing that you should think about is that the patient can be AS, Angst-Pond. So you should go for the HLA-B27, ESR and all those things. Yes, they will be, but they are not life-threatening. No, kuch nahi hota. Worst case, that is what I would say, the worst case scenario is not any complication. The worst case scenario is that patient not getting the desired result or desired relief. So that is more troubling. Otherwise, if you follow the principles correctly, nothing major can happen. Hitting an artery, not artery, or an artery can also, but hitting a blood vessel is not, what should I say? It's not a big deal. Exactly, it's not a big deal at all. But yes, if you find it and you inject the drug in it, that is a big deal. Keep your eyes and ears open. You are not able to do that intervention is also not a big deal. There are anatomical variations. You might fail. But in spite of knowing that your needle position is not correct, you inject the drug, that is a big deal. Otherwise, nothing. If you follow strict sepsis, even chances of infection are extremely less. Specifically for caudal. So if you are giving caudal, make sure the patient has a good personal hygiene. You clean that particular area. If you feel that it is not hygienic, avoid it. So that is one area. Rest, all these interventions are fine. Vasovagal again is very common. It will happen. Extremely common. Specifically the MSK ultrasound that we did. I have seen it. People who have bulky, lot of sports people, they have high vagal tone and they will have. Apart from that, none. Some unexplained things can happen. But again, if you are not happy with the needle position, if you are not happy with the dye spread, please avoid or abandon the procedure. Anything, yes, sir, you would like to add?
The lighter side of it, one of my young patient, after the steroid injection, is still complaining that I have gained weight because of your injection. And now she is 84 kg. And I am explaining her that it is not because of my steroid injection, this is because of your hormonal imbalance. So this is also a complication. She has not yet threatened me for the court or something, but whenever she phones me, she always complains that I have gained weight because of your injections.
None, sir. No contrast allergy per se. But in literature, there is. One more tip and one more clarification. What we are using is an omnipaque dye, non-ionic dye, a cardiac dye. So worst case, even if it goes into an artery, nothing is going to happen. It is just an angiography for the patient.
What he said, you asked about the contrast allergy. You said something like that? It was very common initially when we were using the non-ionized contrast. Now we are using the ionic, non-ionic, water-soluble contrast. Least allergic, but possibility is always there. Always keep an ampule of adrenaline ready. Always, and no doubt about it.
Things that we all, yes, well. Yeah, we do it. Yeah, but the point is something I don't put it and do it. But I will ask any procedure has been done. Most common is dental procedure. So if they have done a dental procedure, so that has been done, taken care of. Yes, sir. No, very good question. See, sir, there cannot be one reason. Infection can also be a reason, right? As I told you, autoimmune angst can also be a reason. So obviously, if you are suspecting any sort of an infection, we will not do it. Any form of active infection, I repeat, any form of active infection in the body, you are not supposed to do any intervention. Because these are not life-threatening situations. So you are not supposed to do it. I hope I answered correctly.
Is there, but we don't know.
We go for a scan, sir. You can go for a scan. You can go for a scan of the of that SI joint, and once you do that, if there is suspected, you go for a blood report. Simple. If anything is suspicious, you will not do it. I repeat, any form of active infection, you should not do any intervention. This is not life-threatening. Yeah, Dr. Tople.
Prerequisite for any intervention is that minimum blood investigation that you will need is CBC, ESR and PTINR. So if you are suspecting infection, there will be derangement of DLC or there will be increased TLC. Okay. If that is there and patient coming with SI joint pain, in that case you can suspect of infection. In that case you can go for MRI.
Eyes and ears तो open रहने ही पकड़ेंगे. No, sir. That is why clinical examination is important. So I will go for an SLRT. If I find the SLR to be positive, then probably I am looking for a radiculopathy. If SLRT is negative but Faber's is positive, then I am looking for SI pathology. But still, I'll give you a more challenging situation. If I get both, my priority will be the top pain first. Right? So what I will do is, if the patient comes to me, I wouldn't run him to a MRI straight away. If he has, nothing has been done, he's the first time seeing me, I'll put him on conservative management of a neuropathic, physiotherapy, NSAIDs, 15 days, things will start settling, then it will give me more clarity. Very rarely, or where I will be like to go for both the investigations, otherwise based on my clinical investigations, I go one by one, and for all those conditions, top pain, higher level pain takes priority. For example, back pain and knee pain. So this is L5S1 space. If there is neck pain and elbow pain,
this is the first.
Neck pain.
Yeah, we are starting the procedure, sir. Dr. Tushar and Dr. Madhukar are here with us.
Yeah. So Dr. Tushar, I'll
Hello. Yeah. Okay. So you can see the ultrasound picture as well?
Yeah.
Okay. So, yeah. So right now I'm in the L5. So this is the L5 spinous process and vertebra, and this is L5S1 interlaminar space. And as I'm coming down, what you can see is the sacral crest. Okay, so medial sacral crest, and I'm just coming to the side of the pathology, that is left side, and jelly. This one, yeah. So right now this is the medial sacral crest, the pointy thing what you are seeing, and I'm coming to the left side. So this seems to be the S1 foramen. Yeah. Yes. So I'll give local anesthesia. So I'll be doing this out of plane. And what we are doing is we're just giving local anesthesia, and then we'll put the spinal needle. And once we are at the location, we will confirm it with the fluoroscopy. So we cannot do this procedure only with the help of ultrasound. So I'm just giving local anesthesia now. So this is an out-of-plane needling, so you may not see the whole length of the needle. So I'm just hitting the superior part of the sacral foramina here. And we'll just take a shot in the fluoroscopy once. L5. इसको थोड़ा shoot picture. So it seems to be in the foramen, so we'll just take a lateral picture. Lateral. Table height, table up.
So since we cannot see the whole length of the needle, so we just see the point of the needle since it's an out of plane technique. So once we hit the upper part of the sacral foramina, and then we take a shoot. Table up. Table up. So we have almost entered the upper part of the foramen. So I'll just enter a little more. Should be fine. So I'm just going to give contrast. Just to confirm and check out if any vascular spread live. Live picture. Okay. AP. It's cotton. Cotton. KV. So this is spreading along the S1 nerve root, and you can see some dye spreading towards the L5, S1 interlaminar space. So we'll be giving the medication, around 5 ml of local anesthetic, 3 ml of local anesthetic plus 1 ml of corticosteroid. Picture. So it's going easily. So just to do this procedure with the help of ultrasound is not very recommended. We should combine this with the fluoroscopy, any spinal procedure, even SI joint, because there are chances of vascular spread. Don't you? Okay. Fine. Okay. So sometimes when fluoroscopy, it's difficult to visualize the sacral foramina. Ultrasound actually can help us to locate the foramina, and then we can mark it, and then we can proceed with the help of fluoroscopy. Done. Thank you. Bandit.
Thank you, Dr. Tushar and Dr. Madhukar. Our next case. Coccygeneum. Yeah. అక్కడ caudal ఇక్కడ నీ RF అయిపోతుంది.
Also will give two-dimensional picture. You can get two views, AP and lateral together. Now these devices are available. In the advanced operating theater, where a lot of neuro-operative surgeries are done, they use both the techniques. Simultaneously in these pictures, lateral and AP both. But what Dr. Dhruv is saying, the objective is to reduce radiation. That is why he is mixing the two, minimizing the exposure to the radiation.
So now this is more of a general principle. This is more of a general principle is that do not rush for an intervention. So for example, it depends where the patient is, when the patient is coming to me. So for example, if the patient is coming with a very recent history, seeing me for the first time, so I will like to at least give medicines for 2 weeks. And when I say 2 weeks, so what I'm looking for is not an absolute pain relief, but a trajectory. Whether this week is better than last week, then I like to wait. That is point number one, how I decide till when I will go for conservative. But maximum but after a point of time, if it plateaus, the patient is not giving us good result, then I'll probably say that now is the time for intervention. On a very practical point, when the patient comes back to me after 15 days, having say a 30% relief, I said I'll hold on, but I will introduce the topic of an intervention that I can target the particular joint in case we do not cross. So that is one. Second thing is, pain medicine is all about personalization. My quality of life would be different from you, sir. And for example, his would be very different. So for example, if I am dealing with somebody who has a very physical job, my threshold to wait will be less. Compare it with an elite athlete. My threshold, my personalization will be less. But still at least 2 weeks is the ideal time that I would like to wait if I feel that I am giving him a new set of drugs and giving a new perspective. For example, if the patient already has his share of conservative management, most of the investigations are done. Patient's life has been compromised over a period of time. I will not hesitate to introduce or in fact go ahead and do an intervention right in the first meeting also. So it all depends upon what kind of a patient are we dealing with, what has been done, and what is our plan of management. So I cannot give you a straightforward thing, but do not jump to it. Wait, but if already done, compromised lifestyle, then the point is do not wait any further. He's coming with a certain amount of hope, then go ahead and offer him. Any other questions? Yes, sir. Yes, ma'am.
Which had a relief for only around 2 to 3 months. So he has come to us and we are repeating a ganglion impar block for coccydynia. So Dr. Anish would be demonstrating this.
Good afternoon, everyone. As you can see on the screen, we have already taken a AP view and a lateral view. So we would like to target the So as you can see on the right of the screen is an AP view image of the lower part of the sacrum, and on the left is the lateral view. So that is the midline which was just shown. We would like our needle and drug spread to be in the midline as much as possible. And on the left of the screen is the lateral view showing the sacrum and coccyx. That is the coccyx, that is the sacrum. We would like to enter at the sacrococcygeal ligament somewhere there and be just anterior to the say coccyx, because the ganglion impar is the terminal coalesce of the sympathetic chain. So we would like to do a diagnostic block to see whether the patient has relief. So I'll first infiltrate the skin in the anal region. Should there? Okay. So I'm infiltrating in the midline. ఒక చిన్న సూదండి. అయిపోయింది. Shoot. Okay, so because that is a very small needle, it is probably not visible on the C-arm. I will go ahead with a 23 gauge Quinky spinal needle. Shoot. So as you can see, my needle has now appeared in the screen. I am a little above where I want to be, so I will redirect it a little inferiorly. Shoot. So now I'm getting closer to my entry point. So I'll still need to be a little more vertical. Shoot. Think I can reach, so I'll go a little more inside. I'm hitting the bone now. Shoot. So I have to negotiate that space. There looks like a fracture there, so I'll be a little careful. Shoot. అప్పవుతుందండి. Shoot. So now we just have to find the space between the two bones. The first and second part of the fused coccyx will have a sacrococcygeal ligament. Shoot. 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 नीचे लोग हैं एंट्री. शूट. बोन ही है पूरा. शूट. చిన్న సోదండి. షూట్. Shoot. Okay now. So I've gone in the lower space. I'll try to turn my shoot. So there is rectum there. So I'll first.
So you have to be very careful because in front there is a rectum.
So I'll turn my bevel facing superiorly. We'll have to aspirate for blood, CSF, and only after negative aspiration should we give around 1 ml of dye. Resistance. Shoot. Okay now.
Give you some more dye.
Shoot. Okay.
Yeah, the dye should be only anterior to the coccyx and the cranial spread is there. So this is how we confirm it.
AP, okay, sir.
And then we'll check for the midline.
We'll check in the AP view again. The thing we have to be careful about is the rectum in front. We are slightly to the right, but it is anterior.
Yeah, but it's okay, we can give the drug now. Anyway, it's displaced coccyx, so that is why it might seem on the right side. But the anterior spread is the most important thing in front of the coccyx. And this it should spread superiorly. I think we should be careful of is the rectum. That's it.
The distance. So we have taken 2 ml of local anesthetic and 1 ml of corticosteroid, and we have injected 3 ml into the ganglion impar. That's it, that's the procedure. Always make sure you put the stilette back and then remove your needle.
Any questions, please?
Thank you. Of course, can
So, we have to inject. Ganglion impar is the terminal sympathetic ganglia. And different descriptions have shown that where it is present. Mostly, say about 70% time, or 48% more precisely, it is at the sacrococcygeal junction. 32% time, it is at the junction of CX, first coccyx, and the sacrococcygeal junction. Another 10-15% time, it may be at different places. What we have done and what we could have missed in this, like we have used second place, second coccygeal. First of all, the needle is going through the intervertebral disc. So this is the intervertebral disc. And sometimes they are the degenerated disc, very difficult to enter. And that is why first space we could not enter. For the diagnostic block, it doesn't matter. You give injection at sacrococcygeal junction, CX, CX1 or CX2, does not matter. Because if you inject about 5 to 8 ml, this will cover completely. But it matters when you are doing a radiofrequency ablation, you have to be very precise. So and also when injecting 5-7 ml, it is an incomplete diagnosis because we do not know exactly that where the ganglion impar is situating, is present. So it is always better to use small volumes. Another alternative is to use 2 needles and do the radiofrequency ablation. So if you are not sure that at one place is there, at least 2 most predictable places, CX and CX1, if you cover, the success rate is almost 80%, 80 to 90%. So these are few tips about the ganglion impar block. It is very good. Initially, it was used for the malignant diseases, but now the non-malignant coccydynia, it is also being used, and it is very, very good, very successful. And complications, the only, it is not a dreaded complication because accidentally you put the needle in the rectum. It's not very uncommon. That is I wanted to tell you. Because his rectum is inflated, a lot of gases are there, then you can identify the gaseous shadow. But if it is gases are not there, very difficult to know exactly where the rectum is and where the needle is. So be conservative. As soon as you cross the posterior table, or the, anterior table, stop there and inject your drug. And the ideal spread would have been the inverse comma, or a linear spread would have been the ideal one.
Ma'am, what is this case? Actually, the patient is exposed, so can we...
This is an elderly male with history of left limb polio with a degenerative disc disease and with history of radiculopathy since 2 months. MRI is showing multiple level discs, so we have planned a caudal epidural for this patient. Dr. Mahesh and Dr. Anusha will be doing it. Dr. Mahesh is doing the procedure and Anusha is there. So the patient IV cannula is secured, the patient is prone, monitors are connected, and yes, we are combining it with fluoro and ultrasound.
Regarding the last question that ma'am was asking, that if patient is just coming for the injection, few things which I generally follow. Irrespective if the patient has been diagnosed by anybody, I would like to see the patient fresh without going through the papers. That is one. Because sometimes there's whatever. That is one. Second thing, it puts a bias in my mind. So that is again a thing. Now, third is more practical thing is that in those cases, if we rush and put in a needle, the moment you put in a needle, it is your responsibility. Whether your surgeon colleague asked you to do it, whether the patient asked you to do it or wanted it. So whenever you are putting the needle, it is your responsibility. Right? So it is, you will have to so if you are convinced that this patient will be benefiting from the intervention, please go ahead and do it. Otherwise, use restraint while doing this patient. And the last thing which I always say, which my teacher used to say is, let the patient earn his intervention. So that is it. But again, on a very practical point, the moment you put in a needle, everything good, bad, ugly happens, it is your responsibility. So as sir gave us an example of a steroid and weight gain. So anything after that is 100% your responsibility. So if we have window shoppers who are saying, he went to you, you quoted X figure, he comes to me and saying he needs an intervention, but since you quoted X, can you give me a discount? And do it for Y. So these things happen. So but the point is, which I always say, if you put in a needle, you are responsible. Then you can't say the patient ne kaha tha.
Hello.
Yeah, I think we will be starting with the case now.
Yeah.
Over to the OT team.
Pointer based. Pointer point.
In this patient, we are going to present the caudal epidural injection. So we are doing the hybrid technique. We are using both ultrasound and fluoroscopy guidance. So Dr. Anusha is showing the ultrasound guided thing. Later I will be combining it with the fluoroscopy and we will perform caudal epidural.
as you can see on the ultrasound picture, the sacral cornua, yes, and sacrococcygeal ligament. So we'll be turning into longitudinal view. That is the epidural space. So once we mark it, then we can give a local here and confirm with the CM. You can take it.
First, we start with scanning of the S1. And slowly we will go down till we see the sacral hiatus. Bit again. There you can see it. So now we will go to fluoroscopic view later.
Bed table height.
Yeah. Fluoro.
Can we have the focus on the needle entry site?
Yes, sir.
No, the surgeon's procedure site. Can you, in the picture, can you increase the size of the procedure? Yeah.
Table down. Table down. What? Table down. Table down. Anchor down. Table down. Ah. Right.
Shoot. Shoot.
Yes, no, it is fine.
So we are giving local anesthesia.
I think we can make it 50-50 now. So half the procedure side and half the image, fluoro image.
Shoot.
Can you enlarge the fluoro images, please, also?
Shoot. 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 First we will do with the ultrasound guidance, then we'll confirm it with the fluoroscopy.
So sometimes the spine could be
Calcifications will be there, and it's very hard to enter the caudal canal in the old age patient specifically. ఇంకా కింద నుంచి వెళ్తుంది. Now you can see the needle is coming in plane. Now we will confirm it with the fluoroscopy. Shoot. You can see the needle is in the canal. So now we will confirm it with the contrast. Shoot. So you can see the contrast spread is very clear and
fluoro images, please.
Fluoro images.
Not the ultrasound, the fluoro images, please.
Shoot. So you can clearly see the contrast is spreading APV.
Excuse me. Oh.
fluoro. Table height.
So can you see the fluoro images now?
No, we can't. So that was we were requesting, can we have the lateral images from in fluoro and then we can have the AP images?
Yes, sir, we are dealing it with. In 1 minute we can see the fluoro images.
Sure. And we can, I think the ultrasound has been removed, so the ultrasound, yeah, that is fine.
Koncham brightness. So that is the.
So in caudal epidural we can see spread of the contrast. We can call it a Christmas tree appearance.
Now can we have the...
Sir, can you see the fluoro images now, sir?
I can only see the lateral image. Yeah, now we can see both the both. We can see both. We can see both the lateral and the fluoro.
Yes, sir. Shoot. So we can see that that's a typical Christmas tree pattern of it.
Yes. Now we can appreciate.
So now we are mixing the Kinacot and the local anesthetic 0.25%, and we are giving 8 ml of volume into the caudal canal. During giving the drug, patient might feel bit pressure inside the canal. So we have to alert the patient that it might be painful sometimes while injecting the drug into the canal. Shoot. We can see the contrast disappeared and the roots can be delineated nicely. So So patient is feeling bit pressure. So that's why we are giving it very slowly. So when you are doing hybrid technique, when you have an old patient, it's always better to combine both ultrasound and fluoroscopy to do it very easily. Because if there is calcifications, it's very difficult to enter the canal. So always use ultrasound and fluoroscopy guidance to do the caudal epidural.
Any questions? Anything? Yes, sir. I agree. So what we generally do is, as I told you, sir, so this is the sacrum. So the direction of the foramen, is in the anterior posterior direction. So it is going to be like this. So what we generally do is we put the C-arm right in the AP view. We go go caudally. You will be able to see the foramina. So open it. You either have, mostly you will have to do either a caudal tilt or a cranial tilt. That's it. You will get a, you will get a semi-crescent kind of a image which will be there. So for example, this is the foramen, right? So when I'll try to observe it, it will be like a semi-crescent. So you just need to target this part. So you will hit it, and once you walk around it, you will get a feeling as if you are falling into a ditch. Tuck, tuck, dum. And then you need to confirm it into the lateral position. I think any technical thing that you would like to add, doctor? Sir, sacral के लिए, fluoro guided sacral के लिए any technical thing?
You see, there are the two ways we can optimize the image. The objective, not particularly for the sacral you are asking, or for all lumbar procedures? Sacrum. Sacrum is like this, what he has said. So for the upper, you have to go on the opposite side, on the caudally. And then for the lower one, you come down sacrally. That is the way you can optimize. And ideally, anterior and posterior tables should be aligned. Crescent is the better way, because ideally it should be round, both anterior posterior. But as I said, practically it is not always possible. Because if you are trying to focus one foramen, it is okay. But if you are trying to maximize, then it is not possible. One foramen you can see the total through and through, but others will not be able to see. Upper and outermost.
So what I generally say is that bone is your friend. So whenever in doubt, hit the bone. So hit the bone, just try to walk over it, and then you will fall into it. So that would be there. Again, a practical tip. I think sir talked about it in, I think, SI joint. It's the same principle follow here. Do not give lot of dye. Because if you are in wrong position, you will never be able to do it. Because it will, again, the area will become black and it will become totally obliterated. So give a little bit and see how it is responding, and then you can give larger amount. And if you have a bad day, fluoro is not working, patient, whatever, even caudal will also can reach up to that level. So you can redirect it that way. So do not stress yourself, because S1 can be technically difficult, specifically if you do not have a well-experienced technician. So one practical tip is that if you are doing it, you set it before you go and wash. So there is no point you have washed up and then you are showering. I generally don't do it. I am a purist. Pyar karo to pura karo. So it's like dye is also undiluted. So depo-metrol also I use a minimal undiluted amount.
हाँ बात हो गई on
yeah, Dr. Tushar, you are on.
Okay.
Usually prefer a double diluted contrast, like I take 2 ml of contrast and 2 ml of distilled water, so that if this issue happens, then next time you can use a concentrated contrast without any dilution, so you can able to differentiate between the darker contrast than the lighter contrast. Anything, whatever is available.
Yes. Steroid. Yeah. Because sir, this is very small amount. So why would you like to keep it in the middle?
Always, whatever, whether alcohol, phenol, or steroid, or whatever, always flush. Either with the saline or with the air.
New one.
And to avoid the tracking. Otherwise, the drug might create a canalization effect, and the canalization will be there, and sinus may form.
Our next case is...
More common with alcohol or next case, ma'am.
Hello.
Yes, ma'am.
Yeah. Our next case is a 50 years female with right knee pain. X-ray showing 3rd degree grade 3 osteoarthritis. Connected లేదు
The X-ray is not clear, ma'am.
Yeah, 1 second.
Can they focus it properly? So the images are not clear, either dark or too bright. Yeah.
Just a second, sir.
Sure, ma'am. Yeah, now it is better, ma'am.
Yeah, okay. Yeah. So we are demonstrating a genicular RF for this patient. She doesn't have a lateral side pain. So we'll be demonstrating superomedial and inframedial.
Yeah,
Dr. Tushar would be...
superomedial, infiromedial, and medial branch of now to vastus intermedialis.
Okay.
So these three will just target.
Extra set. You have extra set.
Table height? Yeah.
Any doubts, questions regarding radio frequency? So what is radio frequency? Why we are doing radio frequency? Yeah, Meri Marzi. So why radio frequency? Yeah. It's an ablative technique. So just previously we had a discussion where we discussed about alcohol and phenol. So that is chemical denervation. This is denervation with the radio frequency. Is there any other form of innervation that you are aware of? So what basically with radio frequencies we are increasing the temperature. Anything else? Cold means what is called, sir? Cryo. So these are the three techniques: either cancer, radio frequency, or cryo. The advantages of all of them. For example, with chemical, the problem is that you cannot be you cannot restrict it to a place, so it will spread. With radio frequency, you can be more precise. They are equal. So there are few conditions where you can use both. Some conditions you can only use RF. There are certain preferences for where I would like to go for chemical, because if I have to get that spread, if I have to get that volume. So generally for me, if it is a plexus block, I would like to use chemical because I need to get that spread rather than using RF. If I need precision, where I don't want even anything to go beyond a certain limit, I will use.
Do you have a spinal needle, 25 gauge or 26 gauge? Which one? Ah.
They have to do it soon.
For giving local.
Yeah. Separate needle.
This one, yeah. Pro cover.
किससे जाना?
25.
23. 25 on. 25 है needle और 24.
Table up. Yes. Gauze piece. Saline. So, can you all see the ultrasound image?
Yes, we can see, sir.
Okay. So,
ultrasound image we can't see. We can see you and the probe in the close-up, but we are unable to see the ultrasound image. Can we have the ultrasound images, please? Yeah, now we can see.
You can see the ultrasound image as well.
Yeah. Oh, can we request? See, we are getting the settings also there. We would like to have a look at the image of the USG, not the settings and all the. Yeah, fine. You can start, sir.
Okay. So you can see the probe position as well, I think.
Yes, we can see the probe position and we can see the ultrasound image.
Yes. So, so for the first thing, what we'll target is the medial branch of nerve to vastus intermedialis, which is at the junction of the condyle and the shaft of the femur, along with the genicular artery. So exactly in the center of the screen, ultrasound screen, you can see the pulsation. So that is the genicular artery, one of the genicular artery branches. So I'm just going to mark it, and this is a long axis scan to the femur, and I'll just make it short axis because we are going to do the RF ablation parallel to the nerve. So just try to identify the artery in a long axis so you can see the pulsation over the shaft of the femur there. And I'm just going distal to that, and I'll be giving local anesthesia. So I'll try to go as much as parallel to the nerve. Small injection, huh? So I'm using the spinal needle so that I'll give the local anesthesia till the periosteum. I'm not going to stimulate in this case because we are nowhere closer to the motor branches here. So you can see my needle piercing the vastus.
Can we have the larger image of the USG? Yeah, USG. Yeah. This is fine. Thank you, team.
So I'm just piercing the vastus medialis muscle, and I'm just at the periosteum, near the periosteum, just above the artery. So I've given the local anesthesia there, and I'm just giving it through the tract of while coming out. So this is for the medial branch of nerve to vastus intermedialis. So this is the CoolF needle. We are going to do cool RF ablation.
Dr. Tushar, we used to call it superomedial. Now you are changing the nomenclature. So just
yes. So basically, earlier as a conventional thing, three needle approach. So we used to call this as a superomedial genicular nerve earlier, but most of the cadaveric studies, have shown recently that what we used to say superomedial genicular nerve is actually the medial branch of nerve to vastus intermedialis. So that is what we are branching, and I'll show how to do the RF of the superomedial genicular nerve as well. Just trying to look at the pulsation, which you can see there. It's very close by, and I'm just going to go the midpoint of the shaft of the femur. So it's very close to periosteum, so it can be a little painful. So just caution the patient about it, and you can see the needle as exactly at the midpoint of the shaft of the femur there. So I'm just going to give some local anesthesia before we do the lesioning. I'm giving about 1 ml of local anesthetic. And I'm just going to connect the electrode now. I'm just going to remove the cannula and place the electrode. So I'm just going a little closer to the periosteum, because the nerve lies very close to the periosteum. Yeah. So again, that is the midpoint of the shaft. So it's confirmed. I'm just going to pierce that fascia, and then we can, I think, start the lesioning. Yeah. So I'll just show you the short axis view also. So this is the tip of the needle. The needle actually you can see as a dot there, and as you can see going down there. Just going to reposition the needle slightly, getting it closer to the artery. So I'm just going to reposition this with the help of the cannula again. So we have to try to be closer, as much as closer to the genicular vessels. That is the genicular artery. So now I think we are close to the pulsation there. Okay. Yeah. So now I'm just going to insert the electrode. Check if you are in the center of the shaft. Your probe is. So sometimes you can get this artifact because of the air. So now you can see that my needle position is just above the pulsation, and I think we can start. I'll give some local anesthesia, and then probably we can start the lesioning. Since I've repositioned the needle, I'll give around 1 ml of LA. Okay. So we can start the this thing, RF. So you can see my needle tip is exactly in the midpoint. So I'm just going to slightly pull it because the cooled RF lesion is more at the tip of the needle, whereas the conventional is more parallel to the tip of the needle. So you can see the pulsation just in front of the needle, and yeah, so that's exactly there. So we'll start. No, treatment, yeah. Slide to start. That side, right side. Right side, yeah. Start. So the impedance is around 450. So we are fine with that. And now we are starting the lesion. So the patient might have, slight discomfort or pain depending on the patient's sensitivity. So just tell the patient that, half a minute she is going to have the pain. So we are doing cold RF since we need a little larger lesion. 20 seconds, Amma, pain, okay? Conventional, there can be a little more pain because we go up to about 80 degrees for 90 seconds. So this is cool RF where the temperature is around 60 degrees for 2.5 minutes. So the needle usually goes through the vastus medialis muscle, okay, which is okay, but we should avoid going through the quadriceps tendon, which is going to be more painful. So you can see the entire tip of the length of the needle, and the lesioning, probably you see some irregularities over there. So this is medial branch of nerve to vastus intermedialis, and superior-medial genicular nerve usually lies a little deeper. So the important landmark for that is the adductor tubercle. It lies close to the adductor tubercle, just posterior to the adductor tubercle. So that is the newer landmark, or the newer approach to block the superior-medial genicular nerve. So we are not going to do superolateral for her because she doesn't have she doesn't have pain on the lateral side. It's mostly on the medial side, and you can see her the osteophytes as well, and meniscal degeneration also. So you can see some irregularities in the meniscus there. So it is common with osteoarthritis. So we're not doing anything for the meniscus right now because it's purely due to the osteoarthritic changes, and slight meniscus extrusion is there. Okay, but we don't have much effusion or edema for synovial thickening or effusion in her knees. So we are done with the one lesion. So I'm just taking out the needle, and then we will, to the same to the same site, we are going to go to the superior-medial. We are going to block the superior-medial genicular nerve. So I'm just starting again. So this is the shaft of the femur, and I'm going down. So you will see the flattening of the femur bone, which is the condyle, and it becomes more superficial, and the adductor tubercle is little more sharp, has a prominent so that pointy thing what you're seeing here on the exactly in the center is the adductor tubercle, and you can see a pulsation over there. So basically that is also genicular artery along with that. So we need to target that, and usually I use the same needle insertion, but I think for her, this is 7.5 needle, so we need to take another point for her. So again, so this is, so you can see the genicular artery as well. So I'm giving the local anesthesia again, small injection, no? So along the needle trajectory, I give the local anesthesia till almost the peak of the adductor tubercle there. I'm just going to as much as parallel possible, and again there might be some discomfort because it lies close to the periosteum again. So we can reduce the depth actually a little bit. So we'll get a better picture, yeah. So again we are very close to the genicular artery there, and my needle tip just lies over the adductor tubercle, and this is where we will do the lesioning. So again I'm going to give a bit of local anesthetic. So for the local anesthesia we have to be careful about the dose. So what I've done is I've taken 5 ml of lignocaine and 2% lignocaine, I've diluted to 5, so that is basically 1% lignocaine. So we're going to insert the electrode.
Have you sedated the patient? She looks very quiet.
Yeah, we have given mild sedation. So yeah, so that is the tip of the probe, and I think we can start the lesion there. Start, yeah. So again we do one lesion here. If there is if we are using the conventional RFA, we might need to do strip lesions where we do 2 or 3 lesions along the mentioned targets. Sometimes this tubercle can be superficial, so we have to see the depth of the tubercle. So here it is around 1.5 centimeters. So there's no risk of any injury or burns. So this is the second lesion, which is for the superior medial genicular nerve. Next we'll be targeting the inferior medial genicular nerve. So the knee joint is supplied by almost more than 10 genicular nerves, of which we are blocking around 3 nerves here, which are important. If the patient is having lateral compartment is also involved, then we do superior lateral genicular nerve, nerve to vastus, intermedius. Lateral branch of nerve to vastus intermedialis, and then also the branch of recurrent fibular nerve. So this we consider when there is lateral pain also, lateral side pain also.
If you are blocking the supply of intermedialis, it won't create any weakness in the limb?
These are all just the articular branches what we are blocking, so it will not cause any kind of motor weakness, or even most of the people ask if it can cause Charcot's joint or neuropathic joint. So these are all just the articular branches, and since the knee is supplied by many genicular nerves, the chances of Charcot's joint is almost nil. There is no case reports also linked to the RF ablation causing Charcot's joint. So these are just the articular branches. They go and supply the capsule of the knee. So, and what we are blocking is just the anteromedial capsule probably. And even if the patient is having posterior knee pain, this is not going to help. So we need to do maybe an IPAC block, or we cannot do RF there because of neurovascular structures, but maybe we can do chemical neurolysis. There are studies or papers where they do phenol neurolysis for the posterior capsule. So we have done with the superomedial, and then we go for the inferior-medial. I'm just going to remove the needle and the cannula. So after you finish your procedure, make sure you do a scan, and you scan the area to see if there is any collection, hematoma or anything, because Genicular, the needles used in cool RF are a little larger, so it can injure the genicular arteries. Rarely it can cause hematoma. So coming to the inferior-medial genicular nerve. So this is a joint line, and this is femur, downside is your tibia, and we are trying to identify the medial branch of, inferior-medial genicular artery. Sometimes it's very, visible. Sometimes you need to, So sometimes when the artery is not visible, so we can actually go to the junction of condyle and shaft, and this is the advantage of ultrasound. I think most of the times we see the pulsations. Can we put the color? See in the left side, yeah. So you can see the vessel there at exactly at the junction of the shaft and condyle. So again, I'm going to turn my probe to the short axis of the tibia, and I'm just going to reposition the patient's knee. Just hold it. Yeah. So let me confirm again. She is moving the legs, I think. So I'm just giving some local anesthesia now. So there is my needle coming in. So I'm giving again 1% local anesthetic. So make sure you're not in the vessel when you give the local anesthesia. So inserting the RF cannula. Okay. Need to give a little more. So we'll wait for some time for the local anesthetic to act. Okay. So I'm inserting the RF needle. So that is my RF needle, and again my target is at the midpoint of the shaft of the tibia. Again, inferior-medial genicular nerve is again very superficial, so you have to be careful about the skin burns. So you can see the needle in short axis now again, and it is close to the junction of the shaft and condyle. So I think we might need to reposition slightly. The color, please. I think we have it there. Yeah. Okay, you can just remove. Okay. So again, you can see I'm just at the midpoint, and again I'll confirm in the short axis. So this seems to be fine. Okay, so I'm going to give local anesthetic again before the lesioning. So after you insert the cannula, the electrode, make sure you recheck the position, because sometimes it is prone to move, and I think I'm at correct position. So I think we'll start the lesioning. That is exactly at the junction of the shaft and condyle, near the pulsation. Yeah. So along with the RF, it's important for us to integrate all the lifestyle modification and physical therapy exercises. It's very important. So since it's close to periosteum, it can be a little painful. So you can see the lesioning. So she is saying that there is some burning. Okay, Amma. 20 seconds. 20 seconds, yes. So usually inferior medial, there is a chance of skin burns, because it's very superficial. So make sure you're in skinny patients, I think your depth should be at least more than 1 centimeter to 1.5 centimeters. we're almost done with the medial side lesioning. So after this, I'll just show you how to position for the superolateral and lateral branch of nerve to vastus intermedialis. Okay, you can take this. So usually to do blocks or RF ablation of the superolateral genicular nerve, you need to just do a slight internal rotation of the leg. Okay, and if you can see the probe position, it is again, we start again with the long axis to the femur, and this is simple, just find the junction of the shaft and condyle, and you will see the pulsation exactly at the center, and that is your genicular artery again. And after you identify the artery, we turn the probe to short axis of the femur, again identify the artery in long axis, and then do the lesioning there. So this is a lateral branch of nerve to vastus intermedialis. Earlier we used to call it as superolateral genicular nerve. So to block the superolateral genicular nerve, which is quite inferiorly and deep, so what we do is we again scan, look for the shaft of the femur, and as we go down, you will see the shaft, widening there. Okay, so that is the condyle of the femur, and the spike what you're seeing, the edge of this thing is basically your posterior cortex, junction of the posterior cortex and lateral cortex. So usually the genicular nerve lies in that region. So to do the lesioning, we slightly need to position. We cannot position exactly like this because it's the patella is very close by. So then what we do is we just the upper end of the probe, we just rotate it and keeping that spike in the position. Now you can actually enter from slightly oblique direction. So this is how you do the superolateral genicular nerve, and in some cases I also do the articular branches to recurrent fibular nerve. So basically again this is the iliotibial band on the top, what you're seeing attaching onto the tuberosity, and as you go down you will see the tibialis anterior muscle along with the pulsation also. So in the center you can see the genicular artery. So this is where we do the RF ablation. Again turn, rotate it, see the artery in long axis, and we do the RF ablation. And you can see that we are actually very far from the common peroneal nerve here, which is on the fibula here. So this is the fibula, the shaft of the fibula here, and we are very far from that. So you can see how far we are from that. So this we all do in the mostly the patient has generalized knee pain, which involves medial and lateral compartment osteoarthritis. Thank you. ठीक है ना? आएंगे.
Tushar, what is the solution where you are dipping the probe? That's not betadine, right?
Sorry? The solution for the scanning?
Saline.
It's saline, yes. So we don't use, betadine, it can cause chemical synovitis, or even whenever you're using, we clean it with saline also. We don't use terlium also. It's only saline. Pressing.
He's IT guy.
Of the pain management. When they come, we give larger volume. We cover 2-3 routes because the objective is not to diagnose a particular route, to give a patient pain relief. And there, the academics fails. But as you are asking for a particular question, there is a particular answer for that. So depending upon what actually you want and what actually you expect from patient, then only you can be very specific for particular treatment or technology. But regarding the epidural, cervical epidural, and please use catheter. There are another 2 points because you cannot risk the dural puncture there. It happens, but you don't want. So when you inject the drug, and if it is outside the epidural space, then again the problem which we are discussing since morning, a lot of clogging will be there and you cannot see the tip. And it is a matter of millimeters, not a centimeter. But when you put the catheter, if it is not in the place, catheter will not go. First thing. And the catheter is going and you are seeing tip, that is an answer. And that also gives you a precise entry of the needle. No other position.
And one more thing is that, again, if you go from AP to lateral, you will need a lot of manipulation, which with a cervical needle in situ, I will not be comfortable. So, thoda sa kiya, cut ho gaya tha. Any other question? Otherwise, you can think over it. We all are available for one more day tomorrow. Workshop. Right? Any other questions? Fine. Yeah. I think that is fine, man. Fine. I think when we are done. Yes, sir. Yes, sir. No, I'm here, sir. I'm out of my home, so I have no liability. But otherwise, what I will request is that these interventions, if done correctly, are safe, effective. But yeah, and do not worry too much about complications. Proper, the magic happens in the OPD, not in the OT. So your counseling fails. Interventions do not rarely fail. So basically, you have to choose the right person for the right intervention. Because the success, unfortunately, of all these interventions is highly dependent on the patient, how he or she takes it. Right? Yes, sir. There is a very good book by Spine Interventions by Lakshmaya Machikanti. Maya Machikanti is and Vijay Singh. I think he is from Andhra only, settled in US. He is was the president of American Society of Interventional Pain Physician, ASIPP, founding president. There is a book in which he talks about all the intervention as if he's standing there and doing it. It's a black book with golden markings. There are 2 books. One is for spinal interventions and one is for non-spinal. That is a very good book. I found initially 6 chapters are just on the basics of fluoroscopy and everything. So I think Lakshmaya, you got it? Lakshmaya, you Google it, you will get it. Lakshmaya Machikanti and Vijay Singh. There are one is black, that is for spine intervention. One is green one, that is for non-spinal intervention. Lakshmaya Machikanti. I might be pronouncing it in Lakshmaya Machikanti. दोनों की एक है, combined. Vijay Singh. He comes to Andhra. He has adopted a village also. Yeah.
Yeah, I think we are done with the live. I think it was clear and good. I would like to introduce all the faculty who have done the live and the morning workshop who are added on today. Dr. Jeshnu Topal, so please. Dr. Uma Maheshwar Rao sir from Citizens. Did I miss? Dr. Uma Pradeepa. Dr. Lav Kumar. Dr. Madhukar Gaud. Dr. Mahesh Kota. Am I missing anybody? Sridevi, stay there. Sridevi, stay there. Stay there. Dr. Sai Teja. Sai. Istanya Pelper. Dr. Sridevi. Sino? Madam. Madam kitchen ninga. Kitchen. Sai sa.
Huh?
Dr. Sai Teja. Behind the stage person who has done all the work. So a huge round of applause, please. Yeah, tomorrow's cadaveric session will be somewhere.
You should take, no?
It's okay. It will start at 8:30. Osmania Medical College, 3rd floor, Anatomy Dissection Hall. Okay, and I would like everybody to please gather for a photo.
No?
Yes. Nagalaxmi ma'am.
Photo